Hello.
Good morning, everyone. Am I audible?
Good morning, ma'am. Yes.
Good morning, everyone. I warmly welcome you all on
That's it.
behalf of NeuroOptech to this professional optometry webinar titled From Scan to Diagnosis, Mastering Diagnosis in Optometry. So, good morning to all the speakers. Thank you for joining us and all the participants. I request all the participants to keep their microphones muted and post your questions in the chat box. We will take them up during the Q&A session. So without taking much time, let's begin with our first speaker. So in this webinar, we have 4 speakers. So we will start our first speaker introduction. So it's my pleasure to introduce our first speaker, Dr. Sanjay Mehta, sir, a highly experienced optometrist and a specialist in retina, glaucoma, and myopia management. He will be discussing the role of OCT and fundus imaging in clinical diagnosis, highlighting how these tools help in accurate early detection. So the stage is yours, sir. Thank you, sir.
Thank you very much, the whole team. I'm audible? Am I audible?
Yeah. You are audible, sir.
Yeah, thank you very much. Thanks the whole NeuroOptotech team for inviting me to this wonderful World Optometry Week. I really also thank all the other speakers and all the participants here for taking out a small time on a Sunday morning. Okay, I am basically a clinician, so I'll share my screen now. Hello. Is my screen visible? Hello.
No, sir.
Okay. Just see now whether my screen is visible.
No, sir.
No.
1 minute. It's not allowing me to. This you have given any controls there? I'm not able to share it. Uh, mm, uh, is there any controls there from your side? Hello.
Sir, I think you can try sharing it again, please, because there is no other control, sir. We can even share it now.
Hello. Uh, do but pardon? Pardon? It's not allowing me to share.
Sir, there is no control thing, but I'm checking out.
Uh, there is a when I'm doing it, it is not opening it up. That
Sanjay sir, can you just try clicking the third option after the camera one?
the entire screen, right?
Yes, sir. Entire screen, and again you need to tell click the
Yeah, but it
screen.
is not.
Then lower part it is having a share
Yeah,
button.
yeah. Okay, okay, fine,
Then it
fine.
will work, sir, I think.
Now it is sharing it.
Yes, sir. Now we can see your screen, sir. Hanji.
Oh, great. Okay. Thanks a lot. Uh, who was that? By the way, who helped me? Thanks a lot.
Thank you, sir. So Krishna, full screen, sir. You can put it in full screen, please.
Yeah, yeah, yeah. Okay. So, uh, this is 1 minute. Okay. Uh, uh, wait, okay. So I will take briefly to through the because to under first it's very important to understand retina. For me, it is still I am a student of this object share whatever is possible as a clinician. Uh, so all of us as an optometrist, we are all aware of this basic anatomy, but I'll just go through take you through this. So this is very, very one of the most important picture. I have kept it as a on my screen always because I should not forget this. Okay, as you can see, all the layers are there, 10 layers, and this is also very important one because you can see the lamina cribrosa picture here. So this is you'll come to know why it is important. Please go through remember this picture. So there are many ways of looking at the retina, as all of us would have used all this one time or another, or probably still using it. We have direct ophthalmoscope, we have 90D, we have indirect ophthalmoscope. All of them have their own advantage. Uh, and there are few disadvantage also. Direct ophthalmoscope, the view is smaller. 90D again, you have to be very expert in doing this. I admit here that I'm not very good in. I've never used much of this 90D. Of course, indirect, the view is fantastic, but we have to dilate the eyes. We have to keep the patient in supine position. Of course, we can do it in sitting also, but in my journey, what I after probably in almost after 25 years after using all these ones, I found something this one. The left one, picture, top picture you see, that is the first Fundus camera I got. Almost, it has been almost probably 15 years back. I found it in a normal physician conference. Okay. And I said, oh, this is useful. And the picture you see on the retina picture on the bottom is the first picture taken by that camera. And I I used that for about still was about 7 8 years, and I still have that machine. But there were certain drawbacks. I have the view was not that perfect to my satisfaction. At the same time, when it came to small pupil, it was always a challenge, and even a small opacity will used to disturb the view. So then I came across this machine called the one which I'm having in my clinic. Um, and the first picture again taken from that device is you can see at the bottom of it. And there are other 2 3 machines available, a lot available in the market. So you'll let us go through one by one what I want to go through this today. 1 minute. So this is the probably only perfect book picture of retina I have ever come across. It was taken on a World Sight Day, coincidentally. So whatever we see in a book is everything. The book picture is there in this. Right? I have never seen again another picture like this. So we have the optic test is there. When you look at the retina through the non-mydriatic fundus camera, so these are the view around 45 degrees you will get, and these are the things we see. Main is the optic disc, the macula, the artery and veins are there, and and we will be seeing few more things here. There is a nice nerve fiber layer here, okay, which is visible like a patch, white patch over here. 1 minute. Then this is the basic anatomy. We should be remembering always. This is also very important, wherein there is a this neuroretinal rim is there. It gives clues to many eye diseases. Of course, the optic disc is there. Now, this picture also is very important because it gives us the how the nerve fiber layer uh, goes around, and at the superior as well as the macular, it is over there. So this helps in many diagnoses. So these are the optic nerve head. We see in 0.3, 0.6, and 0.95 in extreme cases. So this is one of the first picture which really shook me. Can anyone mute it and mute their mic and can say what you can see in this picture? So when I looked at it first, initially it gave me a very normal picture because the patient, she was around 41 years old. She came for a complaint that she wanted near vision glasses 6, 6, and 6. But when I had a look at this picture, retina, I was really shocked. Uh, can anyone unmute them and see what can find out anything else in this picture? So anyway, I will.
I think it's CSR.
Pardon? Hello?
Hello.
Hello?
Hello, sir.
Yeah.
I think it is CSR.
No. It is not CSR. Okay. So it turned out to be a case of glaucoma. Here you can see, though the cup disc ratio is normal, almost normal, but there is an absence of nerve fiber layer here. Okay. Here it is come out okay, but it is not there. So then I went checked her eye pressure. It was somewhere around 30, both eyes. Both eyes. And by the time she really went to start taking the what do you say the treatment from the ophthalmologist, it had shooted up to 60. Okay, so what we it might look like a normal picture, but it turned, if you see carefully, here there is also a disturbance here in the artery and veins. Arteries especially, you can see the veins are also bit engorged. So the absence of nerve fiber layer, gave me a clue. So generally, a glaucoma picture would look like this, wherein the see here. Also, one more thing which I always observe is this pores over here, the lamina cribrosa pores. 1 minute, sorry. So whenever I see the lamina cribrosa pores, whenever you see one, think of that there is some pathology behind happening somewhere, because the nerve, when the pores are exposed, that means something, there is a loss of neuroretinal rim. At the same time, there is something happening behind the eye, behind the eyeball, I would say. Okay, in form of, it could be many reasons. So this is also one of the classic picture. It's really dear to me. You can see a massive one. It was the case of the eye pressure was normal, everything. So this gentleman, he again came for a complaint of reading glasses. So, and he turned out to be something else. Now, one more feature always one should see is when the optic disc is pale. So, whenever we are looking at the retina, we look at the optic disc. We see the vasculature. We see for any abnormal visible factors like visible factors like any blood hemorrhage is there or any exudates are there. You will come to. But whenever there is a pale optic disc, that shows there is a the optic nerve as well is been compromised somewhere. So always look for that. So this is again one super case I had wherein uh, the left picture you see here was taken in the year 2021, and she came back again after 4 years. And you see there is a massive, this is a case of classical papilledema, uniocular it was. And this, my documenting it earlier helped in helped the ophthalmologists in, what do you say, giving the treatment for in further cases. So what are these advantages of this non-mydriatic fundus camera would be, you can easily document it. It will help in always in future to when you can compare it. Okay. So this is also a case wherein all these patients of them have come for a basic routine eye checkup, and it turned out to be something else. This is a BRVO. She had other problem, diabetes also. She was not aware that her retina is affected. So as an optometrist, when we see this case in routinely, it's is as with a normal complaint, that really helps in when you are using this any any devices which helps in seeing the retina, including this. So these are the common things we come across. Is a massive drusen's. She was around 41 years old only, and she was. So these are the common complaints you can see. This is AMD. So here you can see there are. So when we are seeing away from the optic disc, and you can see here there are a lot of blood hemorrhage, exudates are there, soft as well as, and you can see many of them are just in the developing from being hemorrhages to it is getting developing into solid bruisings over there. So one more thing is this one I've seen. This is very one of the most danger condition, epiretinal membrane, because over a period of time it can lead on to retinal detachment. All these findings have been done in a routine examination only. So that's why I feel why we should not use any these devices routinely in our practice. So there is a case of retinal detachment also. Here you can see at the edges. So this machine always they give collage option also, and by little bit maneuvering the eyes, asking the patient to look and up and down, you can have a much wider view than the routine 45 degrees one you can see. It takes a lot of time, but once you master the skill, it took me some time to. There's a huge catalog also for this, but I feel when you do day to day into practice, this helps. And there is a very beautiful feature also. This for I mean on a this was found in an optometrist only, so we can see the blood vessels nicely going in and around, and in turn the cup is form of a heart. So it's just for fun. So then we all of us we know diabetic retinopathy. So here you can see again, in a routine examination, this has been found. Blood hemorrhages, exudates, soft cotton wool, cotton wool spots, everything we can see it much easy. And of course, this is retinitis pigmentosa. Classical one is this. This is also common in my practice. Many of them with amblyopia, they have this modulated nerve fiber layer. It is routinely seen in many of our patients. This is, of course, Stargardt disease. This is again a case of toxic maculopathy, wherein the person was working in an battery manufacturing company. Was handling batteries for a long time, and in turn, he developed toxicity because of that. So this is CSR. So this gentleman came within probably 1 hour of experiencing blurred vision, and here you can see the elevation here. So I will show you uh, uh, this generally the patient complains of blurred vision, slight one small spot in the view. So this is CSR. I've seen generally we see it in a uniocularly, but I've seen in both eyes also together, a massive one. So now again, this is a case wherein this girl, she had come to me in the year 2020 and she came back again 2025 for a routine eye checkup. So I said, her vision, everything was normal. But what caught me was this arc over here. So I said, I was very suspicious, as well as at the same time, if you see her arteries, she's young. She's hardly now 27 years old. For a 27-year-old to have such a thin arteries really shook me. I said, what's wrong? What happened here? And on top of that, this arc over here. She was exposed to, she went into a marriage and which was very toxic, very abusive, and she could not express it out to her family. So it turned out to be something else. So she went into probably coma for about a week also. So what I found is that the medication and even the hypertension, she went into severe toxic hypertension. She had experienced. So she would have developed this, or there is a thinning of the nerve fiber layer here, which is very prominent, which was absent earlier. So that shows that when we document it, it helps in future one. If she would have come in, probably, if I would have not documented this, I would have taken it as a normal only. So also one more thing I always worry is when there is no cup disc ratio visible. Here in this case, again, she is an optometrist also. So here you can see absolutely there is no cup disc ratio. So when there is no cup disc ratio, all the optic nerve fibers are compressed, and definitely something is wrong. So we have to monitor this type of thing quite often. So this is also one of the drawbacks. One difficulty is when the patient does not have vision. It is very difficult to take picture of because the patient has to look straight. So in this case, it took me about almost about 5 6. I have to try it 5 6 times, and then only I could a picture on this left eye, this one, because she was not able to focus also. This is a very sad case wherein she just was hesitant to wear glasses for either for near or even for a distance, and she kept on prolonging her eye checkup. She had a checkup probably about some 10 years back, and she didn't realize that no, because of her not going for a routine eye examination, her eye pressure was around, when I checked, it was around 60 in one eye and other eye was 45. She lost vision in the right eye. This is again one more thing which I have seen is very unique. Is the parafoveal hemorrhage is there with macular edema here. This is very close case to me, wherein this is a condition called arteriosclerosis. Classical features are there. There is AV nicking is there. Venous huge, it's very thick venous. When I saw using my ophthalmoscope, it was quite thick one, very thick veins were visible, and the arteries were thinned out. Also, one more feature I have seen, I had one more few more pictures. I could not add it, but if you see this yellow spot here, there is a block in the artery here. Okay, I have seen couple of them more wherein massive blocks are seen in this. So that shows that some disturbance is happening in the blood flow and the whole mechanism. And you can see there are some hemorrhages also here. Now, this is also a classical case of hypertensive retinopathy. If you see carefully here in this picture, I am not able to see the macular portion here. So what happens in this non-mydriatic fundus camera, many of the times when the pupil is very small, it is very difficult, or if one has to keep the light almost dim in the clinic when you are taking pictures, but still nowadays it is very difficult. I mean that most of us are exposed to a lot of digital devices, and most of us are having pupil size strength. So this case, I am not able to see how much is what is the macula here. So that's where the pros and cons of a non-mydriatic fundus camera comes. From the patient point of view, they don't have to. It has not to be. They don't have to get dilated. From practitioner point of view, it's very quick. Non-mydriatic, it is. The results are seen immediately. It can be recorded. It can be compared, and it gives a good impression on the patient point of from that we are doing some work. It is visible. And one more advantage is with the help of AI nowadays, these retina pictures are helpful in detecting many diseases much earlier. Especially now, the work is going on only on diabetic retinopathy, not in much. So what are the disadvantages? The pupil size, if is small, it is very difficult to see. It is costly, also, is expensive also. I've in squint and nystagmus, so always there is a we have to maneuver the patient properly. It takes some time to take the pictures properly. Opacities, even a slight cataract in the center gone. We are not able to take any proper picture. For me to see the macula is important, and the lens is, if it is opaque, it is going to be right in the center. The mydriatic fundus camera, though maintenance is, I would say, it's not that much, but still it matters. There are only few non-mydriatic cameras which are having good quality, and it gives a flat view. So when the flat view comes, you don't know how the condition is. So and where the defect is lying in the retina. So that's where the role of OCT comes. So this is exactly the same OCT which I am having in my clinic. So when from the OCT we see the layers are visible like this, as all of us would have come across in our studies, this is how it looks. And this is a typical layout chart given by the in the form of reports. So what they give, see, this is a very, I told you that this picture is there, which is, sorry. So though it looks like this, but when we take that scan, mm, these are all the layers visible. My focus is always on this layer as well as on this layer. Okay. And here you can see that which is the right eye. It's very easy to make out because the nerve fiber layer is going here and the optic nerve is very much here. And this layer for photos. So in many of the conditions, we, as it's written here, AMD and retinitis pigmentosa, this layer is going to get affected. And this area is for glaucoma. Yeah, it is very simple to understand. There is no big rocket science in behind it. Once you keep looking at the images, it's very easy to make out. So the typical report is given like this, wherein this macular cube is there, which gives the thickness. This is the 3D view, and this is the again optic nerve head and retinal nerve fiber layer thickness analysis is given. This is how the chart is. So whenever everything is green, it is fine. They have their own, each machine has their own calibration. So this is how from my machine it looks like this. This is one of the perfect retina I have ever seen. Everything is green. There is a nice, what do you say? All the structures are intact. And this is again the report of a optic nerve head again from my machine. Okay, so I always look for this here, disc area, cup volume. Okay, and how this graph is going. So you will come across here slight. It is different, but it is okay. I'll show you some few pictures. You can understand more. So even there is one more thing I always love. This is this GCC, ganglion complex thickness is there. Features are there in this, and this volume, ganglion cell volume and foveal value is there. So here this gives a idea how good is the optic nerve. So here few of the pictures I'll show you. So this is a case of macular pseudo OLO is there. You can see a nice thickness here. So it should have been a full here. It would be called as a full macular hole. Here it is a very common thing I see in elderly people is posterior vitreous detachment. It has totally detached from the macula. Then this is central serous retinopathy. I showed you the case. So there are some simple wording they use is hyporeflectivity and hyperreflectivity. So here, whenever there is an accumulation of fluid somewhere, so it gives a space here, and that is called hyporeflectivity because it is not reflecting any light from that place. So this is comparison to this other eye, which was normal. You can see this elevation here. So I'll just show you this. How there is another feature of this wherein you can take a 3D view of the how the picture, the macular area looks like. You have options here. So what we saw, the parafoveal hemorrhage and macular edema, it looks in the OCT, it looks like this. So it has been, this whole layer has been disrupted. Uh, and there is an edema here. You can see it. So this is again the same patient which I showed you about this glaucoma. Everything is in red. The whole structure has been destroyed here. And even in this eye, little bit is left. Her vision in the left eye is around 636 left. This one is totally, she is blind totally here. She is 636, she is maintaining with that. So again, the same patient, absolutely the whole thing is gone. So when we see even in some long duration of toxicity due to medications, all that, there also I see routinely a red patch near the fovea. And again, this is the same patient. We can see the papilledema here. And this is not only the old picture, the previous picture, but even this OCT report helped it was helped in diagnosing it as 100% as papilledema, wherein because the other eye though looks a little bit at the edge, it looks little bit inflamed, but otherwise the other eye is totally, there is a massive edema is there. So again, that same patient, I would say, this is the arc which was confirmed by the OCT report here. Okay. Again, this is diabetic retinopathy. So here, these are the hyperreflective points. You can see the water. You are seeing the exudates are massively seen here. Even in this, generally, I always prefer the black and white image because you can see the demarcation much easier. Now, the OCT has both posterior as well as anterior. So here in the anterior OCT, we take the pachymetry is also there, and we can see the corneal angle, which is much more accurate. This particular image, I almost thought that it is a very narrow angle glaucoma, but it turned out to be something else. See, though it was narrow here, but the structure was such that there was a hidden uh, part here which was helping the drainage and all that properly. So sometimes no, what we think is narrow can be something else also. So what helps? It also helps in contact lens fitting also. You can see this nicely. So this patient was given a wrong for a toric eye. He was given a non-toric contact lenses, and he was finding it very the comfort was not there. Sorry, I don't have the picture of the one taken with the wrong contact lens. But when I showed him with this, he was convinced that how nicely it was fitting on the cornea. One more thing is, this is again a case of pellucid marginal degeneration, wherein the OCT was able to pick it up correctly. And I told her that definitely this is a case where the cornea is thinned out very badly. She had a in front of me only within 5 minutes, she rubbed her eyes almost 15 minutes, 15 times, sorry. So this led on to the corneal structure getting altered. And then uh, after the surgery was done, then I gave her a scleral lens. So this anterior OCT helps also in seeing how well the lenses are fitted, are staying on the cornea. So, so, so the advantages are, it is again OCT non-mydriatic. We can take both anterior and posterior there. Results are immediate. Even in small pupil and opacities, the results are quite easy to take and accurate also. The disadvantage is it's extremely expensive. It takes a lot of space, and the maintenance is very high. Every 6 months, every probably 4 months, he comes, my maintenance guy, and he charges heavily, but all for the good only. So this is what I can say about this one. I'll end saying that every retina has a story to tell. If you are willing to capture it, see what is there, and act on it. Thank you very much.